patient actually did to what the computer said that they could do. Okay, so again, when the patient arrives at the PFT lab, we ask them about their weight, their height, their gender, and all of that. We put it inside the computer, and then the computer will spit out a number. So based on your height and your weight and your gender and all of that, this is how much that you're supposed to do. And then we let the patient do the test, okay? And then we compare what the patient did to what the computer said that they could do. So what we're looking for is 80%. If you can do 80% of what the computer says that you can do, then you're fine. Okay, so that's called predicted value. So that's where we calculate percentage of predicted. You take observed or what the patient did divided by the predicted times 100%. Normal is 80 to 100%. Okay, any questions about that?
You have the PowerPoint? You have a copy of the PowerPoint?
Oh, yeah.
Thank
I'm
you.
sorry. I gave you that homework I forgot to.
Thank you.
Thank you.
So the next thing here is, it is important to know how to calculate pre and post bronchodilator therapy, whether you have a significant therapy or not. Okay? So what we do here is that the patient comes in, basically patients that we suspect that have asthma. Okay? We're going to have them blow into the spirometer. That's called the pre-test. We're measuring the flow, okay? So they blow in, take a deep breath, they blow in, and then we give them a bronchodilator, okay? And then we wait for like 10 to 15 minutes and then do another test, have them blow into it. So that's called your post-test. And then you gotta find out the percentage change in flow, because what you're measuring is the amount of flow coming out from their lungs after they have had the bronchodilator. So we go like post-test minus pre-test divided by pre-test, that's 100%. If you come out with 12% or more, then that means that the bronchodilator therapy is significant, okay? Or maybe they can use the word reversible. It is reversible, okay, meaning that the patient will benefit from the use of a bronchodilator. It doesn't mean that you're reversing the disease, okay? So 12% or higher will be significant or reversible. And then you remember the FEV1 is the best thing out there. It never lies, whether you're restrictive or obstructive, okay? The percentage of, excuse me, not the percentage, the amount of flow that you exert out in the first 1 second when you're doing your first vital capacity divided by the amount of volume that you exert out altogether. That's 100%. So they call it FEV1 ratio. FEV1 ratio. Normal is 80 to 100%. But the minimum acceptable is 70%. This is the only one that can go all the way down to 70%. Everything else in pulmonary function is 80% or better. So, in the interpretation of PFT, if you are given this, you might as well be done. Because all you're going to say is that if that number is less than 70%, the patient is obstructive, period. Don't even worry about looking at anything else. Okay? But if it's greater than 70%, well, the patient can be either restrictive or maybe they have normal pulmonary function results. That is wrong with the lungs. Okay? So the patient is doing all of this. There is no predicted here. And then the patient took a breath, and then they blew it out, the first 1 second, we'll see what they blew out, and then we'll wait until they complete the test, we'll see the amount of volume that actually came out. So it makes it work better compared to when you're dividing what the patient actually did to their predicted amount. Okay? So that's why this is the first. Now this is how we classify the magnitude of the disorder. It is 80 to 100%, any one of them, whether it's a TLC or FRC or RB or whatever. That's good. Okay? It is 60 to 79, that's mild disorder. If it is 40 to 59, that's moderate disorder. If it is less than 4, that's severe. Now, in classifying restrictive disease, you use your volume, your vital capacity, fast or slow. Because restriction is volume. You're not able to get in enough volume. If you're classifying obstructive disease, you use your flow. Okay? So you can either use your FEV1, or maybe you can use your ratio. So if both of them are given, the best to use is the ratio. The ratio is always the best compared to the FEV1. Okay, so this is the gold standard of classifying COPD. Now, remember now, we only have 2 COPD diseases. We have the chronic bronchitis and the emphysema. So that's what we're talking about here. So you look at that chart there. Oh, sorry. Slow vital capacity must be equal to, must be greater than forced vital capacity. If you're obstructive, okay, and you're doing forced vital capacity, you're going to have obstruction blowing the air out. So it'll be lower than slow vital capacity when you're exhaling it out slowly. So in forced vital capacity, okay, it will be decreased in COPD disease. But in slow vital capacity, it can be decreased or normal, because when you give them time to slowly exhale out the air, they may get all the air out. Okay? So in obstruction, the slow vital capacity will be greater than the forced vital capacity. So volumes and capacities are increasing in obstructive diseases. You have to know that flows are decreasing in obstructive diseases. Now, look at F4C will be increased because of air trapping. It's part of the RV. The RV will be increased because of air trapping. TLC will be increased. Anytime the RV goes up, F4C will go up and TLC will go up. And usually then that will be over 100% of predicted. So if you tell me that a patient has TLC that is 110% of predicted, well, that's obstruction. That's doing air trapping. If you tell me that they have F4C of greater than 100% of predicted, that's air trapping. If they tell me that they have RV more than 100%, that's air trapping. Okay? Their space will be increased, okay, in obstructive disease. Now, their compliance, they have high compliance, high lung compliance, but they don't have good elastance. So not all the air is being pushed out. When they're breathing again, they rebreathe CO2. So a lot of risk for COPD patients. And now look at all the flows. Now, forced vital capacity is not actually flow, it is volume. Don't get that confused. But when you plot the values of forced vital capacity against time, you get flow. Okay? So, but it is not flow, it's just volume. Now, FEV1 is flow. Okay, that will be decreased in obstructive disease. Forced vital capacity will be decreased in obstructive disease, and it can also be decreased in restrictive disease. what I'm trying to get to. 2575, okay, will be decreased as well in the fertility. That's flow. Then the ratio will be less than 70%, okay, to make it obstructive disease. Now here is a restrictive pattern. It affects the chest wall and muscles. You got stiff lungs, you have decreased compliance, volumes and capacities are decreased in all the restrictive diseases. Again, restriction means that your lungs are not expanding as much, so you can't get enough volume in. And then flows are normal. There's nothing obstructing the airway because it's all down here. Okay. Restrictive disorders, don't even worry about this. If you know the 5C babes, anything else, even if it's something that you've never heard about before, it's restrictive. Just make it easy that way. And then again, these are the normal values for the volumes and capacities. You have to, now, for the numbers, now if you tell me that a patient has, that's my A4C there, 2500. If you tell me that a patient has A4C of 3,000 milliliter, isn't that more than 2,500? That would be obstructive. That's air traffic. So it doesn't have to be in percentage. Sometimes they can give it to you this way. If you tell me that a patient has a TLC of 6,500, that's obstructive. Because that would be more than 100% of predicted. Okay, so you got to know this, just kind of remember this. They have high compliance, more than likely that's COPD. Okay. They have low compliance, they're restrictive. Okay. They have high airway resistance, they are obstructive. If they don't have any airway resistance, they are restrictive. Okay? Okay, so PFT result can be normal, meaning that everything is normal. It can be obstructive, it can be restrictive, and it can be mixed. Sometimes hardly would they give you mixed pattern on the exam. Okay? The only time you will have to pick mixed is when somebody is obstructive. Let's say that FEV1 ratio is less than 70%, and their VC, low vital capacity, is also very low. And then if they don't give you obstruction, you treat mixed. Okay, so mixed will be like you got emphysema and then you have pneumonia. Okay? Okay, so for interpretation, I always begin by looking at your VC. Okay? Now, VC, like I told you, can be decreased in obstructive disease or normal, but it will definitely be decreased in restrictive disease. Okay? So when you look at VC and it's decreased, don't conclude yet. Okay, but VC is the best for interpreting restrictive disease. But just don't rush to judgment yet, because they could be obstructive, not until after you have looked at your flows. Okay? If VC is decreased restrictive, VC can be substituted for postvital capacity. If they don't give you VC, you look for your FVC. FVC can be decreased in both restrictive and obstructive disease. Now, it will be decreased in a restrictive disease because you did not inhale enough, because of your low lung compliance. It will be decreased in obstructive disease because you have something blocking the air from coming out from your lungs. That's secretions or bronchospasms, one overdose. Okay? So, FVC by itself does not really tell you anything. It doesn't really tell you who is obstructive or restrictive by itself. Okay? If FVC is decreased, then you look at your flow. Now, FVC can be decreased in both obstructive or restrictive disease. If it is decreased, then I go to my FEV1, which is my flow. Now, if my flow is normal, then I have restrictive disease. I will conclude if that FEV1 is normal, because the flow should be decreased in obstructive disease, but it's not. Therefore, I will have restrictive disease. Just stop right there. Okay. But where we have problem is, okay, so look at this now. So I have FVC, 50% of predicted. When I go, well, you know, that can be obstructive, that can be restrictive. It doesn't tell me anything. And then I go to my flow, 85% of predicted. Well, flow should be decreased in obstructive disease. It should be less than 80%, but it's 85%. So it cannot be obstructive. It has to be restrictive. Any questions about that? You stop right there. But now, where we have problem is, assuming that if EV1 is 50% of predicted. Well, if EV1 can be decreased in obstructive or restrictive disease. Now, will be decreased in obstructive disease because an obstructive disease patient is not able to exhale enough in the first 1 second compared to their predicted value. It will decrease in restrictive disease because the patient did not inhale enough in. So when they exhale out in the first 1 second, it will be a very tiny volume, then divided by their predicted value. Okay? So that's why we decrease in both. So when it's like this, that's when we have problem. And then the next place to go to then is your ratio. If both of them are decreased, then you go to your ratio next. And then if you look at your ratio, if your ratio is less than 70%, then the patient is obstructive. If your ratio is greater than 70%, then the patient is not obstructive. They are restrictive, or maybe they have normal pulmonary function. Any questions about that? So I wrote everything out here for you. Other interpretation facts. Airway resistance is increasing obstructive diseases and normal in restrictive disease. We talked about that. Compliance is normal or increasing obstructive diseases and is decreased or normal in restrictive diseases. Emphysema is the only obstructive disease in which the DLCO is decreased. Otherwise, DLCO is normally decreased in restrictive diseases. Okay? Normal DLCO, you're looking at a 20 to 25 CO for, what's the unit? Liter per minute, something like that. Or maybe the percentage there. Okay, so now let's do a few here. Okay, so I have this one here, pre and post bronchodilator therapy. Okay, FVC, pre is 69. That's bad. That's bad. It's less than 80%. Afterwards, after the bronchodilator, it is still bad. Well, I know that forced vital capacity can be decreased in obstructive and restrictive disease. Okay, so that doesn't tell me anything. So now I go to my flow there, FEV1. 83% before and 84% afterwards. So that's good, that's greater than 80%. So it cannot be obstructive because the flow is good. Look at your FEF 212, that's also flow. That's good, that's greater than 80%. Look at the other flow, 2575, that's also normal. So the answer here is restrictive, it is restrictive disease. Any questions about that? Okay, so now here's another one here. Forced vital capacity is given. Patient's predicted value is 5.1, and what the patient actually did is 3.3. So we're going to calculate percentage of predicted. So we do 3.3 divided by 5.1, and that's how we get that 64.7%. That's not good. That's lower than 80%. So again, I go, well, it doesn't tell me anything because the forced vital capacity can be decreased in obstructive or restrictive. Then I go to my flow there, FEV1. Well, the patient did 3.18, and the computer said that the patient could do 3.83. So we're going to divide 3.18 by 3.83, and then we got 83% of predicted. Well, that's good. So the patient has normal flow, so it cannot be obstructive. Now, look at the ratio there. Okay, the ratio is greater than 70%. Again, confirming that it cannot be obstructive. Okay? So my answer is restrictive, restrictive. Any questions about that? Here's another one here. Forced vital capacity predicted is 6.1. The patient actually did 4.99. So you divide those two together, we get 81%, 82% approximately are predicted. Okay? And then we'll go to flow there. The flow is low. Okay? Always decreased. Flow can never be decreased in restrictive disease. Never. So what I have is obstructive disease. Now look at my ratio there. So what you look at now, remember now, is what the patient actually did, not the predicted value. We are looking at what the patient actually did. The patient only did 41%, which is not good. Okay? On this one here, we don't do percentage of predicted. We can get their predicted value. We can get what the patient can actually do, but we don't divide it. We don't compare it to what the machine said that they could do. Okay? We look at what the patient actually did. So that would be obstructive disease because the patient did less than 70%. Less than 70%. There's another one here. Forced vital capacity, well, predicted value is 3.5. Observed or actual value is 2.1. So somebody divide that out. 2.1 divided by 3.5 is what? This works. This is not working. What you got? Somebody divide it out?
60%.
60%, right? That's bad. 60% of predicted, that's bad. Well, it doesn't tell me anything because the forced vital capacity can be decreased in both. Well, let me go to my flow, FEV1. 2.1 divided by 2.7 is what?
77%.
Huh?
77.
Is that good? No, it's less than 80%. That's bad. So it's like the one I told you before where I had 50-50. So normally we will go to the ratio now, but the ratio is not given. But now look at the numbers. Okay? The patient was predicted to do 2.5 on their FRC. Normal FRC is 2.5. They actually did 1.7, which is lower than this. Volumes and capacities are decreased in restrictive disease. Look at your TLC here. The patient was predicted to do 5.6, but they actually did 4.2. It's also decreased. So it has to be a restrictive disease because the volumes and the capacities are decreased. So which one of them there is a restrictive disease? Which one of them is a restrictive disease?
B.
B is sarcoidosis, yeah, sarcoidosis. Because acute bronchitis is obstructive, okay? Cystic fibrosis. So it has to be sarcoidosis. Now, sarcoidosis is like inflammatory disease, okay? This inflammatory disease is like when you have infection, the white blood cells will arrive at this site. After fighting the infection, they don't go back away, okay? So instead, that causes inflammation in the airway. All right, so here's another one here. A patient undergoes pre and post bronchodilator testing. Risolabirol is utilized for the test. The results are what's vital capacity before and after. Both of them are greater than 80%. Well, that's good news. FEV1 before and after greater than 80%. 25-75 before and after greater than 80%. The same thing with the 200, 1200, and then the peak flow. Okay? What are you going to do, or what is needed? No therapy is needed as the test results are normal. Protoadrenergic agents, there, MDI. So which answer would you pick? Huh? Hey. Yeah, they don't need any therapy. It's not COPD. Why would you be giving them green treatment? Okay? But now, if I was told that this is a COPD patient, and what the result will not be this way to begin with, then I can say that despite the fact that this came out right, they're still going to need a bronchodilator. Okay? Here's this one here. FEV1 before the treatment is 32%. That's bad. After the treatment, it went up to 53%. That's a great improvement. Well, the percentages are already calculated. If I subtract 32 from 53, that gives me 21, right? 21%. So that's a great improvement, greater than that 12%. It's already calculated for me. So they have significant bronchodilator response. Now let me keep on going here. FVC, 38% are predicted, 38% are predicted, and then after 66, and then look at my ratio there. My ratio is 64%. The patient actually did 64%, which is less than 70%. So then the first thing I know is that the patient is obstructive. Okay? Now, how am I going to classify this? So Well, let's look at A, mild restrictive disease. Well, this is not restrictive pattern here, it's obstructive pattern. Severe obstructive disease with significant bronchodilator response. That is true. Okay, because what you look at is what the patient got before they got the bronchodilator. You don't look at the result after they got the bronchodilator because the bronchodilator may have helped them, okay? So they were severe before they got the bronchodilator to become significant. So look at that 38%, okay? So the answer is B. There's one more here. A patient has the following pulmonary function results. FVC, 56% of predicted. That's bad. But it doesn't tell me anything, whether the patient is obstructive or restrictive. So I'm going to go to my FEV1 next. When I go there, it's 53% of predicted. Again, FEV1 can be decreased in obstructive and restrictive disease. So it doesn't tell me anything. Then I go to my ratio next. 86% of predicted is greater than 70%. So it cannot be obstructive, never. Okay? So now, we keep on going here. The TLC, 75% of predicted, that's lower than 80%. So it's like, instead of that TLC being 6,000, it's lower than that because of restriction. You go to peak flow, their airway is wide open. There's nothing obstructing, it's 108% of predicted. So they're blowing out a lot of air. So that would make it restrictive disease. Any questions about that? Are you loving this? See, I told you, it's very easy. Right, Leah? You just gotta understand, it's very easy.
It's easier than the last time we learned this.
Huh?
It's easier than the last time we learned this.
All right, so here is this one here. The following pulmonary function results are obtained for a patient. Now, in front there, they give you, the FEV1 ratio is given. 90% of predicted. You know what I'm going to say? This can never be obstructive disease. That's all I'm going to say. Okay? FVC is low, so what? It can be decreased in both, but my flow is none. Okay? So this will be, what will be the answer there? Pulmonary fibrosis. Pulmonary fibrosis. That's the only restrictive disease there. Here's this one here. FVC, patient actually did 3.6. Percentage of predictor is already calculated. So we divide